محترم جدا جدا جدا.
اوكي. تمام. So good evening everyone, and good evening our dear friends, thank you so much for accepting the invitation to attend with us tonight. Tonight I'm really thrilled and greatly honored to have on board two of the most elegant professors and teachers of cardiology, not only in Egypt but all across the world. Professor Ahmed Mohsen from Cairo University and Professor Ahmed Farid from Suez Canal University. So this event will be learning in Ramadan. We will have a short glimpse from the hypertension guidelines by the ESCC in 2024. And then Professor Ahmed Mohsen will give us a very interesting clinical scenario. Dr. Ahmed Mohsen has already authored 6 books, Tips and Tricks in Cardiology series, and the most recent one is Tips and Tricks in Clinical Cardiology. So Dr. Ahmed will show us how to think about a case presented clinically and then integrate this into the clinical practice by performing the necessary investigations step by step until we reach the final diagnosis. Professor Ahmed Farid is a master of imaging not only in Egypt but all across the world, and Dr. Ahmed Farid will give us some tips and tricks and quizzes regarding some challenging interventional cases. So without taking more time to this, of course, this event is sponsored by Novartis. I would like to thank them so much and Dr. Samer Farag by name for his support for this event. And it's completely scientific, non-promotional. We would like to thank Eventi also, Nihal and her team for the wonderful organization, and thanking all the attendees for registering with us today. Dr. Ahmed Farid, welcome on board. And
Hello, Dr. Muhammad. How are you?
Thank you so much, Dr. Ahmed, and thank you for accepting the invitation to attend with us tonight. It's a great honor, actually, to have you on board tonight.
It's always my pleasure.
Thank you so much. I will start sharing my screen. So it will be a glimpse, just some figures and diagrams, not too much speaking, but actually what is new in the 2024 guidelines by European Society of Cardiology in the topic of elevated blood pressure and hypertension. So the first thing that will hit our eyes is the concept of elevated blood pressure. And this moves us to the first notification from the guidelines that it is recommended in 2024 and 2025 that the blood pressure would be categorized as non-elevated, elevated, and hypertension. So this is the first update, the new categorization. And this is the blood pressure categories by the ESC guidelines in their figure. I will discuss the non-elevated blood pressure, elevated, and hypertension from the office blood pressure point of view to make it easier. So if the blood pressure of the patient is below 120/70, this is considered as non-elevated blood pressure. If the blood pressure is more than or equal to 140/90, this is hypertension, as we know from the previous versions of the guidelines. And if the blood pressure is in between 120/70 and 140/90, this is what we call elevated blood pressure, which is the new concept introduced in these guidelines. And I will run through with you in the next slides why they introduced this concept. So this is the number, and now this is a class 1 recommendation to categorize your patient into one of those 3 categories. This was a very nice figure by the ESC that shows you that in the green color down on the left, the non-elevated blood pressure systolic is below 120, elevated from 120 to 139, and more than 140 or equal is systolic hypertension. He tells you that a class 1 with the green color is to target your range to be between 120 and 129. And if you cannot achieve this range with the yellow one beside it, you can target the systolic blood pressure as low as reasonably achievable, which is short hinted as ALARA, as low as reasonably achievable, achieving a blood pressure below 140 if the patient is not tolerating the 120 to 129 millimeters of systolic blood pressure. Taking into consideration the older population above age of 85, that those might suffer from orthostatic hypotension, and taking into consideration the frailty of the patient at any age, or if the predicted lifespan is less than 3 years, because if it is less than 3 years, you don't have enough time for hypertension to create a hypertension-mediated organ damage that will ruin the patient's life further on. And at all stages exclude hypertensive emergencies. What struck my eyes also, and I wanted to hint you about, dealing with the patient. Dealing with the patient is screening for hypertension. Of course, this is the first step. You screen the population for hypertension. If the patient is below the age of 40 years, you can take an office blood pressure once every 3 years. If the patient is above than or equal to the age of 40 years, you will measure his blood pressure once every year. Accordingly, you will categorize the patient into one of the 3 categories that we said before. Grade 1 is from 140 to 160 over 90 to 99. Grade 2 from 160 to 179 over 100 to 110. And grade 3 is blood pressure above 180 over 110. As you can see, the intermediate zone, which is the new definition of elevated blood pressure, this is the one that's taken a specific highlight to search for the cardiovascular risk conditions associated in those patients, and putting the patient on the score chart to search for the overall cardiovascular risk, not only the blood pressure or hypertension risk, and search for the risk modifiers. Of course, the discussion with the patient is important. And what is really nice about these guidelines, it offers you the questions asked by the patient. What is the disease label and related symptoms? You will reply to the patient telling him that this is the condition where blood pressure is more than or equal to 140 over 90. And if you are lower than this, but above the 120, up to 70, so if you're 120 to 139 over 70 to 89, we will categorize you as elevated blood pressure. And you will tell the patient, because the patient will say, but I don't have any symptoms, I don't have any complaint. You will tell him that this does not have any symptoms or signs, but if you are in this intermediate zone, we will need to monitor your blood pressure and we will need to search for risk factors and risk modifiers. The patient will ask you, is this illness, hypertension, controllable by medical intervention, or can I just reduce my salt intake and do some exercise? We will tell the patients that both approaches are complementary together. If you are in the intermediate zone of elevated blood pressure, you still have a good chance to start your dietary modification, lifestyle modification, risk modifiers to modify what's going on before you start a medication. The third question, which is very important, okay, I changed my lifestyle or I took a tablet for the hypertension and now my blood pressure is controlled. What should I do? I shall stop the medication. Usually we tell the patient that hypertension is a chronic disease and most probably you will need to take your blood pressure controlling medication, and you should not stop the blood pressure controlling medication whatsoever. I usually describe this to my patient like this is like wearing eyeglasses. You do not decide to take off your eyeglasses in the morning and say, I have a good eyesight, unless you perform a surgery or something. So long as you're wearing eyeglasses forever, you will take the blood pressure controlling medication most of the time forever. What are the physical and psychosocial consequences if I'm not convinced by your opinion, my doctor, and I'm not going to take the hypertension controlling medication? You are at risk of developing stroke. You are at risk of developing a heart attack. Although if you are properly managed and reaching the targets from the medications, hopefully your risk will be alleviated and you will be exactly like a normal blood pressure person that's not taking any medication. Then the patient will start asking you, why is my blood pressure high? What is the reason for the high blood pressure? You will search for secondary hypertension, of course, which will be discussed also. If it's not secondary hypertension, if it's primary hypertension, you can tell him that it's a multifactorial disease involving some genetic factor. If the patient is older age, involving the age. Sometimes there are modifiable factors like diet, weight, physical activity. But more important than searching for the cause of primary or essential hypertension is actually treating this essential hypertension. What extent is the treatment necessary? The treatment is very necessary because you need to reduce the risk of strokes and heart attacks. Does medication have side effects or something? Most of the available medications now have minimum or neutral side effects, and we can discuss the medication classes with the patient in the repeated visits about any side effects for this medication. The WHO in 2003 gave us 5 dimensions for adherence of the patient. The socioeconomic factor, is the drug affordable or no? The therapy-related factor, does the drug have side effects or no? The patient-related factor, is the patient believing your concept and discussion that we just discussed before? And the condition-related factor, you need to explain the patient that hypertension is the silent killer. It does not cause symptoms in most of the cases. So you are taking medication for a disease without symptoms, and the patient needs to be convinced about it. And of course, you need to have a very good clarity of communication between yourself and the patient. Why? As I said, because of all these complications to the heart, to the eye, to the kidney, to the brain, to the microcirculation. All of this need to be discussed to the patient to convince him to start and adhere to the medication. The second point is how to measure the blood pressure. So there are recommendations to measure the blood pressure in the office, at home, and in the ambulatory. I will focus with you on the office blood pressure. You put the patient 5 minutes seated comfortably in a quiet environment using an automatic device, validated device, appropriate size of the cuff to the arm of the patient covering 2/3 of the arm circumference. Putting the patient seated, so you put the cuff on the patient arm resting on the table at the level of the heart, so the cuff and the heart level are both at the same level. Assess for measure blood pressure 3 times, 1 to 2 minutes apart, and discard the first reading, take the second and the third reading. If the difference between them is more than 10 millimeters of mercury, take additional readings. Measure in the first visit the blood pressure from the both sides. Exclude arrhythmias because these automatic devices will not work properly in patients with atrial fibrillation. In this case, the guideline recommends that you use the oscillometric devices, the regular mercurial device, and of course, measure the blood pressure standing position at least on the first visit only for orthostatic hypotension, which is a reduction of more than or equal to 20/10 millimeters of mercury. In the home blood pressure, you need to teach your patients. It's similar steps as you say, and the patient will ask you number 4 and number 5, how frequent should I measure at home? Twice a day for 3 to 7 days, ideally 7 days, and record them, please, whether on the device if it has a memory or on a piece of paper with the morning and the evening measurements. And here, the number for recording is diagnosis hypertension is 135/85. The ambulatory blood pressure also has a specific recommendation. The most important of them is that 70% of the recordings are documented by the machine. If the machine documents less than 70% of the recordings, then you need to repeat the test, and the numbers for the 24 hours is 130/80, including a daytime of 135/85 and a nighttime of 120/70. So the third step after diagnosing the patient is action plan. Why do we take an action plan? We take an action plan because you have patients that might be at risk which require you to take an action plan for those patients with elevated blood pressure, although they are not clearly defined as grade 1 hypertension yet, if they have established clinical cardiovascular disease, if they have moderate or severe chronic kidney disease, if they have end organ damage, cardiac vascular, if they have diabetes, if they have familial hyperlipidemia. Those are called risk factors that necessitate you to intervene even if you did not reach yet the 140/90 margin to diagnose hypertension. The second thing here are the risk modifiers. The risk modifiers, some of them are related only to females: gestational diabetes, gestational hypertension, preeclampsia, preterm delivery, stillbirth, recurrent miscarriage. Those are called sex-specific modifiers in ladies. And there are shared modifiers in men and female, including the high-risk ethnicity, especially the Southeast Asia, family history of premature atherosclerotic cardiovascular disease, socioeconomic deprivation, autoimmune disease, HIV, and severe mental illness. After that, you measure the blood pressure, you assessed the patient risk, you took very good notification of the intermediate zone, those with elevated blood pressure. You will go to calculate the score, or the score 2 for the older population, or the score diabetes for the diabetic population. And if the score, if the risk is lower than 5%, you will go with lifestyle measures and reassess after 1 year. If the risk is more than 10%, you will go with lifestyle measures up to 3 months, and you will start pharmacotherapy if the patient has a blood pressure more than 130/80. This is class 1. If the patient is between the 5 and the 10, you will go through the risk modifiers and the risk factors that we just discussed in the previous slide. If the patient is included within them, you will treat them as if he has a risk more than 10%, and you will need to assess additional risk factors: the calcium score, the carotid and femoral plaques, the highly sensitive cardiac troponins, the N-terminal pro-BNP, and the pulse wave velocity for atherosclerosis. This is nice because this collects actually what to measure for which target organ damage. For example, for the kidney, you measure the eGFR and the albumin-creatinine ratio. For the heart, you are searching for the LVH in the ECG. You are searching for the LVH in the echo. You are searching for the diastolic dysfunction by the echo. You are searching for cardiac biomarkers, troponins, and N-terminal pro-BNP. For the atherosclerosis, you're searching for the plaques, whether carotid or femoral, pulsed wave velocity, carotid femoral pulsed wave velocity more than 10, brachial ankle pulse wave velocity more than 14. This is an indication of atherosclerosis. And of course, if you perform a calcium score CT with more than 100, this is a risk for hypertension and atherosclerosis. Fourth point is excluding secondary hypertension. The guidelines focused on 3 main points for secondary hypertension. Number 1 is primary aldosteronism. Taking care, in most of the cases, it might be asymptomatic. It's just going to present as resistant form of hypertension. Spontaneous or diuretic provoked hypokalemia. AF, disproportionate hypertension mediated organ damage. You're having an LVH, you're having a renal dysfunction, despite the blood pressure is 130/80. Muscle weakness and tetany, or you're performing a CT or MRI or ultrasound for any reason, and then you find a suprarenal mass. This is what we call incidental mass or incidentaloma, a mass that was not expected or not symptomatic for the patient to search for, or a family history, because some forms of this aldosteronism come in familial cases, which are autosomal dominant and autosomal recessive inherited. The diagnosis by aldosterone-renin ratio, saline suppression test, adrenal vein sampling, and genetic testing. And the treatment will be mineralocorticoid receptor antagonist, especially in cases of resistant hypertension, as we will see, and surgically by adrenalectomy. Renovascular form of hypertension, like renal artery stenosis, atherosclerotic or fibromuscular dysplasia, they will be diagnosed by a renal Doppler ultrasound, a CT or MRI in a patient presented with uncontrolled hypertension, multi-site atherosclerosis, flash repeated pulmonary edema, headaches and migraine and pulsatile tinnitus, vascular bruise, reduced GFR after administration of an ACE or an ARBs or a RAS blockade, taking care in the age less than 40, mostly it's fibromuscular dysplasia. In the age more than 60, it is the atherosclerotic type. And treatment include two arms which are not alternative to each other, but they are complementary to each other. You give the patient the optimal cardiovascular risk management, including the antihypertensive medication, and it might need an intervention, whether by angioplasty or surgery, renal stenting and dilatation, and we will not stop the medication despite you do so. You just do that to reduce and halt the damage to the kidney. The third most important is the obstructive sleep apnea, which is increasingly common now because of the obesity, because of the lifestyle, sedentary lifestyle, lack of physical activity associated with atrial fibrillation, especially the asymptomatic atrial fibrillation that can be detected during a Holter monitoring, non-dipping if you do ambulatory blood pressure monitoring, especially at night. Those non-dippers have a high risk of obstructive sleep apnea, especially if they are snoring or their sleeping partners on the bed said they have repeated apneic attacks at night. Of course, it happens because intermittent upper airway obstruction. The diagnosis is by overnight polysomnography done in the specific lab, and the treatment is by weight reduction, CPAP, and mandibular advancement device. So you diagnose the hypertension, you excluded secondary hypertension, you put your patient according to the definition, and you identify the risk modifiers or the risk factors that will mandate you to be a little bit aggressive during interventions to reduce his blood pressure. What are those interventions? Number one, lifestyle modification. Lifestyle modification are diet and exercise. So aerobic exercise is a class 1 indication, at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity, including swimming, cycling, brisk walking. If not, just increase the daily steps. And now it's on the smartphones, on the smartwatches. You can calculate your daily steps, take a stairs, park your car a little bit far from your work, avoid sedentary lifestyle, do not sit a lot on the table or on your office. Isometric resistant exercise training, 3 sets of 1 to 2 minute contraction, hand gripping, planking, wall sitting. Class 1 indication, dynamic or isometric resistance training to complement the aerobic exercise training. As you see, both of them are green, both of them are class 1. It leads to reduction in the cardiovascular risk profile of the patient and reflected as blood pressure reduction because it's associated with weight loss. Increase potassium intake, replace the sodium salt, the sodium chloride, the table salt by potassium salt, increase the physical activity as we discussed previously, optimize the weight management and follow a healthy diet like the Mediterranean diet or the DASH diet, reduction of the alcohol intake, and of course, cessation of smoking. So this is the lifestyle modification. The next step will be pharmacotherapy, or it will be a complementary step started at the same visit. And here we have a very important algorithm. Let's start by the green one, low dose double combination therapy. What are the combinations? Taking class 1, ACE or ARBs, calcium channel blockers, or diuretics. So this is new, or this is actually highlighted as new, that you can start by a double combination low dose. And look at the second green box. The second green box after reassessment by 1 to 3 months is triple combination dose in a low dose. So the low dose double combination is followed by a low dose triple combination, is followed by a high dose triple combination. Those are the first three green boxes. And this is very important, and this is very new as a concept of starting by combination therapy, and it included by name the ARBs or ACE, calcium channel blockers, and diuretics. Taking into consideration the upper box on the left, the gray one, is telling you that rarely you might choose only monotherapy, means a non-combination. Which categories are those? The middle category, elevated blood pressure, 120 to 139. The frail patient, the age more than 85, and the symptomatic orthostatic hypotension. Those represent a very small population of the patients. Most of the patients will be falling in the category that will start by a combination therapy. Low dose double, high dose, low dose triple, high dose triple. On the right side, you can see the green box telling you that at any step, if beta blockers are having a compelling indication like heart failure, like angina, like post-MI, like inappropriate sinus tachycardia where you need an adequate heart rate control, beta blockers are also class 1. In the boxes in the middle, they tell you that you follow up your patient every 1 to 3 months to confirm that his blood pressure is reaching the target. And after his blood pressure is reaching the target, you can follow up at least once every year. So this is the plan. Most of the patients will be controlled. In a small subset of the patients, they will not be controlled, and this is the case of resistant hypertension. Resistant hypertension, you need to test the patient for adherence. Is he adherent to the therapy or no? And you might need to refer him to a hypertension clinic after excluding secondary hypertension. And then you will add spironolactone. What is important here, and I took this slide to show you that in 2018, the statement was like this. Among all antihypertensive drugs, ACE, ARBs, beta blockers, calcium channel blockers, and diuretics. On the right side in the 2024, the beta blockers have been omitted. So this is important to be noted because the beta blockers does not reduce the central aortic blood pressure, and the beta blockers might falsely indicate you a low brachial blood pressure despite a high central aortic blood pressure, increasing the incidence of stroke and endpoints. So it is important to know that beta blockers will be indicated if there is a compelling indication, heart failure, angina, post-MI, inappropriate sinus tachycardia. This is new between the 2024 and the 2018. Finally, how to manage a case of resistant hypertension. Number 1, exclude secondary hypertension. Number 2, you are giving 3 medications, maximum tolerated doses. One of them is a diuretic, and your office blood pressure is still above 140/90. Referring the patient to a specific hypertension clinic to exclude secondary hypertension, pseudo-resistant hypertension, confirm that your patient is optimized and adherent to the therapy. In between brackets, they tell you, ideally, 3-drug single pill combination. This is very important. 3-drug single pill combination. We have ACE, ARBs, calcium channel blocker, and diuretic. So mostly it will be an ACE or an ARB, plus a calcium channel blocker, plus a diuretic on the maximum dose. This is the green box number 3 in the previous slide. If he is on this plan and he's still a true treatment-resistant hypertension, you will add spironolactone. If spironolactone is not tolerated due to gynecomastia or breast pain, you will add eplerenone. And after that, number 5 will be a beta blocker, if not already indicated for a compelling indication. If not controlled on those 5 medications, you will start by adding medication number 6, alpha blocker, centrally acting or potassium sparing diuretic, And if it's not controlled on all of this, you still have renal denervation as a class 2B. Finally, what did we revise tonight? We took a glimpse on the hypertension guidelines ESC 2024 version. There was a new categorization of hypertension, including the middle class, the new one, elevated blood pressure definition between 120 and 140 systolic, 70 and 89 diastolic. We have specific targets in different scenarios, and we have specific targets according to the diagnosis, whether it's office blood pressure, or if it's home blood pressure, or if it is ambulatory blood pressure. How to measure and how to interpret the blood pressure, addressing the patient's inquiries and concerns. Most important is focusing that this is a chronic disease, it is silent, does not have symptoms or signs, and it will need a chronic intake of medications. This is very important. Assess and encourage the patient's compliance. Before you decide that this is a case of resistant hypertension, you have approaches to manage hypertension, non-pharmacological, including the diet, the exercise, the physical activity, the weight reduction, the smoking cessation, risk modifiers, and risk factors. And then you go to the pharmacotherapy as we discussed, low dose double, low dose triple, then high dose triple. Pharmacotherapy algorithm in managing hypertension, secondary hypertension, focusing on the aldosteronism, focusing on the renal artery diseases, stenosis, and focusing on the obstructive sleep apnea as secondary hypertension. Defining resistant hypertension, accurately diagnosing resistant hypertension, and taking into consideration step 4, 5, and 6 of pharmacotherapy, and finally going to renal denervation. Thank you so much for this session, and thank you, Novartis, for sponsoring the session as well. And I will take 2 minutes to discuss with Dr. Ahmed Mohsen and Dr. Ahmed Farid if they have any points to discuss about this. And I see that we have one question maybe on the panel. Yes. How about diastolic hypertension, in which patients have elevated diastolic blood pressure over 90, while systolic is normal or mildly elevated? Any thoughts? Definitely. Definitely we have thoughts about this, as we can see that the definition included between 70 and 89, it will be in the middle zone, exactly like the 120 to 140, and above 90 is diastolic hypertension, will be treated exactly like above 140. So diastolic hypertension is still there. Diastolic hypertension will be treated. And as you can see here from this definition, I'm sharing the slides with you. You can see here the diastolic blood pressure is mentioned according to whether you measure it at office, at home, at ambulatory blood pressure, day or night. It's still there within the definition and still will receive the same medication exactly like the systolic hypertension. We have a second question. Why choosing low triple therapy before giving high double therapy? Yes, this is the guidelines flow chart. It went like this. This is important because giving a triple therapy on a lower dose, you get lower side effects and you get additional synergistic effect. So actually, it's more effective and less side effects to give a single pill combination with 3 small doses rather than giving 2 medications on big doses. And what about the approach of isolated systolic hypertension in frail and old age? Definitely, this is the box, that small gray box on the upper left side on this slide, as you can see here. This one, it tells you, I will magnify, this is the magnification. It tells you that in those particular category of patients, you will give a single medication. This is the category of patients that you will have extreme caution with dealing with them, and this is the category of patients that will receive a single medication within the flow chart. A fourth question: is eplerenone valid for hyperaldosteronism? The first option is spironolactone by the guidelines, If spironolactone causes side effects, then eplerenone is the alternative, but the first one is spironolactone. This is a very smart question, actually. I will move the floor to Dr. Ahmed Farid and Dr. Ahmed Mohsen if they want to have a short discussion before we move on with the next speaker, Dr. Ahmed Mohsen. So,
Thank you very much, Dr. Muhammad, for this very elegant and concise lecture. And actually, I think that's the more challenging is to diagnose hypertension. This is the most critical part. I think if you just diagnose it right, then the management will be rather easy. The problem is that I can say that the wrong diagnosis of blood pressure, either to the overdiagnosis, when you just rely on one reading, that you just give the patient medication and he start complaining of low blood pressure symptoms like dizziness, headaches, and even may have deteriorated in kidney function, or you may miss it at all. So you may measure the blood pressure at certain time of the day where the blood pressure is good, and you miss the part where the patient had an elevated blood pressure, like in the night. That's why the recommendation is to measure at the home readings. You have twice daily measurements. So the diagnosis of hypertension, I think it's the most critical, and I think in these guidelines, it's well addressed and well prescribed. What do you think about that?
this is very important and very smart and very practical. And this was addressed by the guidelines. Give your patient 5 minutes of rest, a quiet environment,
Yes.
seated, arm supported, arm and heart at the same level, cuff adequate size, and then you measure 3 measurements. You throw the first one, you take the second and the third, and if the difference between them is more than 10 millimeters of mercury, you repeat again until the difference is less than 10. And within the text of the guidelines, it said, if the difference between the two arms is more than 10, you will mark this arm as the arm that you will always be measuring the blood pressure from this arm. It's very important. In some cases, the ambulatory blood pressure monitoring is important, especially in cases of white coat hypertension. If it is suspected, you take an ambulatory blood pressure, taking into consideration that the device records more than 70% of the recordings. Thank you so much, Dr. Ahmed, for this discussion. Dr. Ahmed Mohsen.
شكرا جزيلا يا دكتور محمد على المحاضرة الرائعة. أنا بس هقول كده نوت صغيرة. أنا رجعت
Yes.
الاتنديز كلهم عرب، فحقيقة مش شايف داعي
That's
قوي إن
good.
إحنا
Okay. We can discuss in both languages. It's okay, because
Yes.
on that channel we have like 11,000 subscribers. So some of them are not Arabs. And this will be uploaded to the channel as well. And of course, you can upload it to your channel as well. Of course, Dr. Ahmed, you're most welcome.
Okay, thank you so much, dear Dr. Muhammad, for the kind invitation and for the elegant presentation as usual.
Thank you.
I
I have
think
2 questions on the screen. They just appeared now. Which
sure.
group of medications for isolated systolic hypertension? I can pass this question to Dr. Ahmed Mohsen, actually, because he's a little bit focusing on the tips and tricks in hypertension. Which group of medication, Dr. Ahmed, would you prefer for isolated systolic hypertension?
Very nice question. I think the preferred group in this subtype of hypertension is either calcium channel blocker as first choice and ROS blocker as a second choice. If you are
Yes.
going to use a single agent, it is better to use calcium channel blocker. As you know, isolated systolic hypertension is common in elderly, and the recommended group in this type is calcium channel blocker.
Perfect. This comes from the concept that the patient that has isolated systolic hypertension is usually one in the gray box. He's usually the elderly one to have extreme atherosclerosis, to have only isolated systolic, or he's the very young one that has tachycardia. So most probably you want to reduce the central aortic blood pressure to reduce the incidence of strokes. So calcium channel blockers and RAS blockade, yes. Combination of calcium channel blocker or RAS blockade in small doses is also okay. If the patient is young and this isolated systolic hypertension is just due to tachycardia, maybe in this case, you could start by beta blocker. The second question is a CKD patient who needs triple therapy but cannot tolerate ACE or ARBs due to hyperkalemia. What would you prescribe for this patient, Dr. Mohsen?
CKD
with
can't
triple
tolerate ACE due to
ACE due to
hyperkalemia.
hyperkalemia, and he's not controlled on the low dose double combination, for
Okay,
example.
actually, I have prepared a full lecture about management of hypertension in patients with CKD, and these type of patients are classified into two different categories: CKD without dialysis and CKD maintained on dialysis. The lecture is uploaded on my YouTube channel in
Perfect.
English version. So
Perfect.
I advise you to revise this lecture, and it will answer all questions.
Thank you so much, Dr. Ahmed. Most probably in this case, either you have one of two options, I think, practically speaking. You can add a potassium chelation, because now we have new potassium chelating therapies which have zero side effects or minimum side effects, and they are available in the form of sachets. Usually, this patient, you can add this kind of medication for him, and then he can take the triple therapy. Otherwise, you can give the high dose double therapy, not including the ACE or ARBs, and then you can pass yourself to the beta blockers, the centrally acting, the alpha blockers. You will go through the same cascade like the resistant hypertension, but without adding the ACE or ARBs. If you need to add the ACE or ARBs, you can give the potassium chelation as well. Thank you so much. It's my great, we have a 7. Okay, this will be the final question because this is number 7. What can we do for patients who have resistant hypertension even after giving all treatments? Renal denervation is not available in our country. Okay, so it's available in Egypt. We do have it in Egypt. And I think it's available in all the Gulf areas now. India, available in Asia, available in Europe. Maybe you are speaking about the price or the expenses. If the patient is really resistant hypertension, like he's taking the 3 medications in the full doses in the single pill, and you add number 4 and number 5 and number 6, and he's still really resistant hypertension, I think you will give the maximum tolerated doses of all those medications, and you will see what is the basal blood pressure after this. If the blood pressure is 140/90 or less, you will accept it as it is. You will not target the 130/80 or the 120/70, and you will control the associated risk factors and risk modifiers to reduce the risk of this patient. Otherwise,